It's a cool rainy afternoon in Accra, but somewhere in the Ridge Hospital, the heat is building up. James Wombe, an anaesthetist, and his team have just been called in for an emergency surgery. Their patient is only hanging on to life by a thread. A visibly pregnant Adjoa, not her real name, has suffered a placental abruption. This is when the placenta separates early from the uterus, cutting off food and oxygen to the fetus. It will only take an expert team of anaesthetists, doctors and nurses to save the life of the mother. Thankfully, we've been granted unlimited access to today's procedure, but not before we put on our protective clothing. So now that I've gone through all of my safety procedures, I have on my scrub, I have my face mask and my cap. I'm now ready to enter the operating theatre. The anaesthetists must first set the stage for the operation before the surgeons arrive. These professionals are in charge of administering medication to allow the procedure to be done without pain, and in some cases, without the patient being aware during the procedure.
The first drug that we have just given is Tayo. Tayo to make the patient sleep. That is the anesthetic drug. Now, when the patient sleep, before the Tayo, we give what we call a pain reliever or analgesia. So the analgesia is first. That takes away pain, followed by the Tayo, which is the anesthetic that makes the patient sleep, and then followed by the last part, which is a muscle relaxant. That will make breathing to cease. So we are giving the muscle relaxant now.
Another milestone an anaesthetist must cross is intubating the patient to allow her breathe even under paralysis.
This tube has been put into the airway at a certain specific area. If I fail to do that, now having done this, we are listening to the lungs. That's why he's doing, to find out and see whether the tube has entered the right place. Sometimes this tube can enter the stomach. And when the tube enters the stomach and you don't recognize it, the patient goes off. Now, if I fail to do what I have just done now, and I need help, somebody to assist me, it must be right here. This is not something that if you are doing it and you fail, you have to stop and call somebody who is not in the theater. Okay? Because this patient is not breathing as at now. And so, having put the tube into the correct place, I am now going to breathe for this patient. Okay? Through the machine. So right now, I am breathing for this patient. You see? I'm breathing for this patient. And I can see from my machine, you see the rise of this. We call it the capnograph. The one going up and down white. Okay, this tells me that I am in the right place. Okay, so I certified myself. In certain jurisdictions, mostly in some of the hospital or in certain remote areas, you may not have what we call the capnograph to be able to determine whether you are in the right place or not. You will have to listen to the sound of the chest. Okay? And that will tell you that you are in the right place or not. Okay. So we are okay?
It's bilateral.
Bilateral. So having listened and it's okay, I will now do what we call mechanical ventilation. Okay. I have given the briefing to the machine to do it for the patient. Okay. Right. Okay. So now it is a machine which is now briefing for the patient. Okay. No more me. Okay. Initially I was doing it, but now I have given the work to the machine to do.
Now all is set for the surgery to begin. A few minutes on, there's organized chaos towards saving a life. The perioperative nurse on the case, Selina Tre, says it's a normal occurrence.
Surgery like this is how it should be. It's an emergency surgery. So every team in the operating room should make sure that they give out their maximum best to ensure the survival of the patient. So in a normal operating room, in an emergency setting, this is how it should be like. Everybody is running up and down just to see to it that we get a successful surgery.
For 3 full days in April, not all patients were fortunate enough to have the services of anaesthetists. A nationwide strike by the Ghana Association of Certified Registered Anaesthetists made it impossible to undertake planned surgeries in hospitals across the country. Their protest was against a move by the Medical and Dental Council to change their name from Certified Registered Anaesthetists to Physician Assistants. The anaesthetists argued and still argue that they could not be called assistants for a job they clearly do in the absence of a doctor of anesthesia.
In the area of anesthesia that I can always talk about, even in the bigger cities in Accra, we don't have enough anesthetists. What then happens down there at the district level? There are some of the district, the whole hospital has only one anesthetist. In some, they have two. And like I said, any hospital that have one anesthetist, ethically it is wrong for one anesthetist to be there. It simply means that any time that this one anesthetist struggles to anesthetize one case, he has done the work of about 2 or 3 anesthetists. But we don't have them. So what do? That's why this issue of supervision, this issue of calling us physician anesthetists, physician assistant anesthetists is becoming a big problem. People who are breaking their back, doing all the sacrifices around. Yes, in fact, in real sense, areas that are less resourced, this is where you should have probably the physician anesthetist working in. But this is areas that people are breaking their neck. This is where area people are suffering, and yet, to a large extent, people don't want to appreciate it. Look at here. We are about 3 anesthetists with students. See how we are struggling. Imagine if this is one anesthetist. It means that you are really, really in big trouble.
Mr. Wombe, who also doubles as the president of the Ghana Association of Certified Registered Anaesthetists, rather wants government to boost the profession by creating more avenues for career development.
The state needs to do more than they are doing to create subspecialities, one, to also create the avenue for people to specialize in areas of their interest, like it is done in all the other disciplines. Currently, anesthesia is one of the professionals who do not have a subspecialty. After you have finished the basic training, that ends it. You will work and work and work. Okay, but if these subspecialties are there, it will enable people to go to areas of their interest. Now, where you are so happy in doing, you do it and do it better. And now, beyond that, as a form of remuneration, when you have a subspecialty, you become a specialist, and that also enhances your salary. Yet, we don't have it. So it is like for you, you just keep doing the work. Keep doing the work. You keep doing the work. But what would, enhance your own personal capabilities and enhance your well-being, you don't have. So it's the biggest challenge, and I'm saying again, the policymakers in Ministry of Health, Ghana Health Service, and stakeholders will have to look at it. If they don't, sooner or later, they'll lose the entire, human resource within the anesthesia. Because people come to do the anesthesia, come to learn anesthesia, they work, and because of frustration, they begin falling out. So that is why, though you train, but you don't get the numbers. You train and it leaks. You train and it leaks. Okay? So the government will need to do. Look, and the government should take the responsibility of paying for the subspecialty programs.
So it's been all hands on deck in the past 30 or so minutes that this surgery has been going on now. The doctors have successfully been able to remove the not viable baby from their patient. And what they are doing now is just cleaning up after the surgery. That cleanup quickly went south after the doctors discovered that bleeding from the incision wouldn't stop. The emergency nature of the surgery had forced doctors to start without blood on standby. And after several calls to get supply from the blood bank have proven futile, time is fast running out for Adjoa.
Right now, the anesthetists, they are given IV fluids. They are also given medications just to supplement, but still they need the blood for the surgery to go on successfully and also for the survival of the patients.
A few more hours go by and the team manages to bring the bleeding under control and concludes the surgery. The anaesthetists extubate the patient and by lowering the levels of anesthesia, bring her out of paralysis. Now her road to recovery. After almost 3 hours of being on the table in the operating theatre, this patient is out and would be spending the next few hours right here at the recovery ward. Reporting for City News, my name is Nii Armah Amah.